Good afternoon, everybody. Welcome to my Monday afternoon Instagram chat at the Fertility and IVF Center in Miami. I'm Dr. Michael Jacobs, and welcome. Today's topic is in vitro fertilization, IVF, understanding decision-making with ovarian stimulation. And, a lot of times I think this is kind of a bit confusing to patients, and so it's a good idea for everybody to understand what the vocabulary is, what we're trying to achieve, and what's different about ovarian stimulation compared to normal ovulation and so forth. And the first premise to understand is that what we're trying to accomplish in IVF is to get more eggs than you normally produce in a month. In a normal cycle, you make one egg, and in an IVF cycle, we're trying to get 15 or 20 if we can. And the response of the ovary is going to be based on the intrinsic ovarian reserve of the ovary combined with how much fertility drugs we stimulate the ovary with. And so first, just some definitions. A lot of times, you hear us use the word cysts or follicles or eggs. And in essence, we can't see eggs on ultrasound. Eggs are microscopic in size, and you can only see them under the microscope in the laboratory. The eggs develop in a lake of fluid, and as you're in a normal cycle, as the follicle, which is the fluid-filled lake that contains the egg, develops, it gets larger and larger. And so we've learned how to correlate the size of the follicle, which is in essence a cyst. It's a fluid-filled containing structure in the ovary, and anything that's fluid filled is a cyst. So you have these cysts on the ovaries that are the follicles where the eggs live, and they develop normally in a cycle with no fertility drugs. You get one develop, and then when you're using fertility drugs, you have multiple ones develop. And if we're trying to achieve restoration of ovulation in somebody who doesn't ovulate on a regular basis, we're trying to get one or two eggs to develop, basically, which means one or two follicles. With IVF, the more eggs we have at the end of the day, the better chance we have of having more embryos and normal embryos from a genetic standpoint. So with IVF, the goal is not one or two eggs, but ideally 15 or 20 if we can. And we do that by using injectable fertility drugs to stimulate the ovary to develop the eggs that you see at baseline into more mature follicles or fluid-filled cysts where we can get eggs from. So when you come in at the very beginning of a cycle, we do a baseline ultrasound. It's an ultrasound, it's not at the beginning of the cycle, hence the word baseline. And we look to see how many little black lakes you have on the ovary. At that point, you should not have anything that's over 10 millimeters. And the little tiny follicles that we see called antral follicles are between 2 and 10 millimeters. And those are the ones that potentially will respond to fertility drugs and develop. When you come back during the stimulation, before we're ready to retrieve the eggs, these little black lakes are increasing in size. And the artsy part of what we're doing is to adjust the amount of medications that we're giving you to try and get the most ideal response we can, and the ideal response being in that 15 to 20 range. Sometimes we'll get 30 and sometimes we'll get 5 depending on the ovary. But we try and stimulate you to get in that sweet spot so we have a good number of eggs to work with. So at baseline you come in, we do an ultrasound. We should not see any cysts larger than 10 millimeters. Sometimes it might be one that's 12 or 13 that we don't care about. But usually you like to have the antral follicles all to be small in that 2 to 10 millimeter range on average diameter. And then you start the fertility drugs usually on the 3rd day of the cycle. If you're coming off of birth control pills, it would be the 4th day after the last birth control pill. If you're on an estrogen priming protocol, it's after the period comes down. So the key is we do an ultrasound, we make sure everything is okay, and we start you on the fertility drugs. We usually will bring you back after 4 days of injectable fertility drugs. And the point of that is for us to see how many of these follicles are growing, have they increased in size, what is the hormone level that these follicles are making, how much estrogen is being produced, and it lets us make a decision, everything looks okay, or we need to adjust the medications up or down. And the amount of estrogen that's being produced that we think is an acceptable value changes depending on what protocol you're using. If you've been on an old-fashioned kind of protocol with lupron down regulation, if we have a value of 100 to 400, that's pretty good. If we are on a antagonist flare cycle, whether it's coming off a pill or not, that 100 would be a low value. Usually we see values in the 300 to 700 range. So the amount of follicles, the size of them, and the estrogen level give us an idea of, okay, this is okay, or should we increase the medications and so forth. So the initial evaluation is at baseline to see that there's nothing that prevents us from starting. You start the fertility drugs, and the first ultrasound, usually after 4 days, is to give us a handle on, are we on the correct dose, or do we need to change it to get a better response? Or if we do a blood test on that day and we see that you're making 40 follicles are present because it's a PCO type ovary and the estrogen level is 1,000 already after 4 days of medication, then we're going to need to decrease the amount of medications because we don't want that drastic an over response. So the first ultrasound after 4 days of medication is a check for us to see where we are and how to adjust things. We then will bring you back anywhere from 1 to 3 days later. And what we're looking at for the second ultrasound while you're on the fertility drugs is to know when to start this medication called the GnRH antagonist, which is cetrotide or Antagonist, and ganirelix or cetrotide. And these are medications that get added to the fertility drugs, and the purpose of these medications is to prevent ovulation from occurring. So it prevents you from having an LH surge on your own. And prior to the availability of these drugs and Lupron, about 20% of IVF cycles would get canceled because people would ovulate prematurely. And as you know, these medications are very expensive. So by adding in, and it's called a GnRH antagonist, that medication will prevent ovulation from occurring and having us needing to cancel a cycle. So when do we add that medication? It's usually between after 5 or 7 days, in that range. Most of the time between the 5th and the 7th day of stimulation, we add the antagonist, and that's just to prevent ovulation. The fertility drugs will adjust as needed, and the other factor besides how many days of stimulation you have is how big are the follicles. We like to add the antagonist when the leading follicle is in the 13 to 14 millimeter range. So if you come back on, let's say after 6 days of stimulation and the follicles were all tiny and the leading follicle is only 11 millimeters, we're going to probably have you come back in a day or two before we do anything different. But when we see the leading follicle being 13 or 14 millimeters, we add the antagonist. Now, what do we mean by leading follicle? If you look at the follicles as they're developing, and sometimes we'll say eggs, but we're not really looking at eggs, we're looking at the lake of fluid that the egg sits in. You basically are assessing how many are there and what their average sizes are. And just like if you look at eggs, and you buy a dozen eggs in a store and you open up a carton of eggs, they're all different sizes. And when you look at follicles developing, it's very rare to have all the follicles develop at exactly the same rate. So it's ideally, if you had a big parade of people, you would love them all being shoulder to shoulder walking down the street, and all these follicles would be exactly the same size, and you'd have this perfect, very narrow bell curve where almost all the follicles line up very close together, and there are a couple outliers. In reality, they tend to be some that are more advanced and some that are stragglers, and the closest we get to that ideal is sort of a skewed bell curve where more of the follicles are grouped together, and you got a couple of outliers and a couple of stragglers. But when we see the leading one, meaning the biggest one, being 13 to 14 millimeters, that's when we want to add the GnRH antagonist, the ganirelix or that prevents ovulation from occurring, so that we can continue to push the smaller follicles to get bigger. And so the next ultrasound, the third ultrasound, is really just how are we doing? Do we need to adjust the medications up or down? Are we getting close to the time period where we trigger ovulation? And again, we're looking at a combination of the follicle sizes as well as the amount of hormone that are being produced. And obviously, if you're producing 10 or 12 follicles, we have one blood test of an estrogen level, and that estrogen level is the summation of all the hormone being produced by all these follicles. So it's impossible for us to know how much is being made by each follicle. We only can see the sigma on the blood test of all the follicles contributing a little bit. But from lots of experience, we know how to correlate the two, so we have an adequate hormone level for the number of mature follicles that are developing. And as you get closer to the time where the eggs are ready, we see you more frequently. So we may have you come back in a day rather than 2 days. We want to see you as often as we need to, and that's based on the potential of making a decision regarding adjusting medication or triggering the eggs for ovulation. So we don't want to go too long, but if we know nothing's going to change if today is Monday and things look a certain way, and we know that bringing you back tomorrow isn't going to change anything, there's no point for you to have to come in, have an ultrasound and a blood test, and have to worry. So we'll bring you back, usually every other day, and then as you get closer to being ready to have HCG trigger every day. So what is this key point where we want to trigger the eggs, basically? By triggering the eggs, we're talking about using usually HCG, human chorionic gonadotropin, and in cases where there's a very strong stimulation and over-response of the ovary, if possible, we would use either Lupron instead of HCG or Lupron and a low dose of HCG to minimize the risk of hyperstimulation syndrome. And that key point usually occurs after between 10 and 12 days of stimulation. Sometimes it could be a little earlier, sometimes a couple of days later. But in general, it's around the 12th to 14th day of the cycle that the eggs are ready. And at that point, what does ready mean? The leading follicle should be at least 18 to 20 millimeters, and the second group of follicles 15 to 18 millimeters. Anything between 15 and 20 is going to usually contain a mature egg. Mature eggs are ones that we're able to fertilize, and those are the ones most likely to result in embryos developing down the road. If you never have all the follicles at the same size, so you're trying to reach this point where you have at least 3 of them that are in that 18 to 20 range, and a second cohort between 15 to 18. And at this point, it's a little bit of a balancing act. We're looking at the total number of eggs, and we realize that if we go too long, if we wait till your follicles are 22 and 24 millimeters in size to trigger them, we might sort of overcook and have an over-mature egg that won't work as well. So we have to look at the big picture, and if we see that, okay, there's one 22 millimeter one and a 17 and an 18 and a couple of 15s, but you have 6 or 7 and a 13 or 14, we may push one extra day with the idea that, well, okay, we may lose the leading one, but we'll pick up 5 or 6 more in exchange. So that's a good trade-off. If you have a group of, let's say there are 8 follicles altogether, and 6 of them are in the right range, and you have 2 others that are 13 and 14. In that case, it doesn't pay to try and wait another day, because if we lose, we're not going to gain anything. So the decision as to when to get your eggs is going to be based on a couple of factors. One is the total number of follicles, the sizes of those follicles, the amount of hormone that's being produced, and the balance between the number of mature eggs, potentially good eggs, and the immature eggs. So we're trying to get as many as we can into that sweet spot so that we have the best number of eggs to work with, and usually that gives us a good collection of mature eggs. A mature egg is one that has the first polar body extruded and can be fertilized by a sperm, and we don't know that until we get the eggs out. Now, how do the number of follicles present correlate with the number of eggs we get? Usually follicles 15 to 20 millimeters we'll get an egg out of. We try and get eggs out of everything. Sometimes we'll get an egg out of a 12 or a 13 millimeter follicle, and it can be a good egg. But eggs that are in smaller follicles tend not to come out as easily. They tend to be immature eggs, and that's why they don't release easily from the ovary. And we try and get whatever we can, and then we'll try and fertilize whatever number of eggs are mature. But the total number of follicles does not correlate with the total number of eggs that you get. The follicles that are in that 15 to 20 millimeter range is the best correlation to what we might expect to get when we retrieve the eggs. And then obviously the maturity of the eggs is going to depend on the individual, how much hormone is being produced to nurture those eggs, and how many eggs we have in general. So we can predict a little bit on what to expect. The maturity of the eggs, we can predict also a little bit based on how many are the right size in that 15 to 20 millimeter range and what the estrogen levels are. And so we can have a little predictive value for you when you ask how many would I expect and not. But don't confuse the total number of follicles. If you have a PCO type ovary and you have 40 follicles, but only 15 of them are good size, we're not going to get 40 good eggs. We often will get eggs out of smaller follicles, but they tend not to be as good as far as meaning a good egg, meaning a mature egg, one that we can fertilize. So that's kind of the super nuts of ovarian stimulation, what we're looking for during retrieval. Before retrieval, how we make our decision making, and why we make the decisions that we do. Our goal is to give each individual the best chance to get pregnant, and we try and treat each patient individually as the cycle goes on to try and optimize that result. There are some general principles that are followed to make those decisions, but rest assured that we're making the best decision for you as an individual. We're not treating everybody exactly the same. So have a good afternoon, stay safe, and hope this information has been helpful. Have a good day, everybody.